There are three parts to this talk. The first part is about neuroscience and psychiatry. And in some ways, this slide is one of the most important of the talk. It's introducing the idea that when we're talking about people, there are different levels of description of how we describe people and how we have what kind of theories we have about how they work, really, how their minds work and what their minds are. So this slide has neurobiological, psychological, sociocultural, and spiritual. Now, there's many different ways to kind of come up with different levels. These are not the only possible levels you could come up with, but they are they make a good deal of intuitive sense. And certainly, since the introduction of kind of the human sciences, there's been a lot of discussion about how do these different levels of theories or levels of description fit in with each other. What is one level more fundamental than another level? This sort of debate has been going back at least into the 19th century. In fact, probably well before then. So it's a debate with a great deal of history. And so the main one of the main ways to kind of set out the debate is to talk about reductionism versus non-reductionism. And in some ways, I think certainly a lot of Western psychiatry has a largely kind of reductionist bias. And the basic idea of reductionism is it thinks that the higher levels of description, the kind of spiritual, the socio level, the psychological level, they should all be in some ways reducible to what it considers to be the most fundamental level, which is the neurobiological level. So there's this idea that in order for a theory to have scientific validity, it's going to have to fit in with a neurobiological description. And I think this idea is a very powerful one in our culture, and certainly if you look at modern psychiatry, you'll hear that sort of idea a good deal. People talk a great deal about the brain as if the understanding the brain is the most fundamental level of reality when it comes to understanding people. On the other hand, non-reductionism denies this and says that our higher levels of description of people have to be don't have to be reducible to the neurobiological. So I'm going to be defending a non-reductionist view. I'm going to be defending the idea that you can have these different levels of description, but one level doesn't have to be reducible to the other. So let's just think a little bit about psychiatry. I imagine most of you are pretty familiar with at least the basic idea of psychiatry as it's practiced in the United States and maybe elsewhere too. Now, psychiatry is not something that is very strictly defined. It's certainly a medical profession. It's generally thought to be part of medicine. And there's certain psychiatric training that you have to undergo in order to be a psychiatrist. But where we draw the lines between psychiatry and psychology and other forms of helping people, that's there's a big gray area there. But the basic idea of psychiatry is it's meant to help people who are suffering from mental disorders through medical approaches. So I'm a philosopher, and so when I hear a claim like that, I'm particularly interested in, well, what do we mean by phrases like helping people? Is it making them happier, or is it making them more functional members of society? Or is there some other understanding of quality of life which we should take into account? There's a great deal of debate about what counts as a mental disorder. And there's plenty of debate in modern society about whether certain conditions are really mental disorders or are kind of social problems. So those are sort of big debates. And then there's questions about how do we distinguish medical from non-medical? So those are certainly big issues that come up in this sort of debate. Then, apart from what is psychiatry, we can ask, what do psychiatrists do? And basically, they meet up with patients and often potential patients, and they come up with diagnoses or tentative diagnoses about to say what their problems are, and they recommend treatment. Now, certainly in the United States, the treatment is most often prescribing medication. So among adults receiving outpatient mental care, medication only use was around 62% in 2021 in the United States. So a significant majority of mental health care is providing medication. But there's other treatments too, and there's certainly quite a good amount of psychotherapy. And psychotherapy can be performed by psychiatrists and clinical psychologists. Sometimes it's in conjunction with other forms of therapy, and sometimes it's just psychotherapy alone. So there's medication and psychotherapy, but we should also bear in mind other forms of treatment which are commonly practiced within psychiatry and maybe increasingly recognized as being important. So there's mindfulness and meditation, exercise and physical activity, nutrition, sleep hygiene, social support, nature-based interventions, and then kind of art and creative therapies. So maybe those are more rare as forms of treatment, but they are still reasonably commonly practiced. So there's that's psychiatry and forms of psychiatric treatment. And then if you're thinking about the levels of description, we're talking about psychiatric theory. And that can be, it's a little bewildering if you look at the psychiatric textbook or talk to psychiatrists about what their theories are, because there's so many of them. And there are different levels of description. Sometimes there is a mixture of levels of description. Sometimes the theories are compatible with each other. Sometimes they have competing theories. So it's a big mix of theories. And it's certainly quite confusing. So some are at levels of brain activity, some are at levels of conscious thoughts and experiences. And it's probably true that psychiatry is especially a domain where people disagree with each other. It's somewhat difficult to find psychiatric truths which all psychiatrists agree with. So psychiatry is an area where there's a good deal of debate. And I think that's an important aspect of our thinking about the nature of psychiatric treatment and help. So here's just a little diagram about the different kinds of theories. You have psychodynamic theory, biological theory, humanistic theory, cognitive theory, and behavioral theory, and they all kind of mix together. So it's quite it takes a lot of time to try and get it in your head. So one sort of debate, one question we might ask is there a core of well-established psychiatric theory, stuff that everybody can agree with? And as I was already just saying, it seems to me that the defenders of psychiatry, the representatives of psychiatry, will say yes, there's a core. We can know what kind of the essence of it is. On the other hand, that's not necessarily agreed with by everybody in the mental health field or philosophers. And when you look at all the debates, it's quite difficult to find a real core which everybody kind of solidly agrees with. That's a fairly major issue, I would say, in terms of where. I'm not necessarily going to say there isn't a core, but I think it's certainly up for debate whether there's a real core knowledge of psychiatry or whether it's just a bunch of different theories. But I tend to think that it's pretty hard to identify a real core of psychiatric knowledge. So going to this idea whether psychiatry is based on neuroscience, certainly you often hear that idea. The most common idea we hear in modern culture is that a mental disorder is due to chemical imbalances in the brain. The idea is that there are neurotransmitters in the brain, such as serotonin, and then a lack of serotonin was the cause of depression. And there have been similar theories about a good deal of psychiatric disorders, and the schizophrenia comes as one of the main ones. One thing to say about that is that none of those theories have actually been empirically verified, and it's as a matter of constant kind of debate, and there isn't. It's certainly possible that in the future, maybe one theory will eventually be proven, but at this stage, that none of these theories have actually been proven, and it hasn't been shown that any mental disorder is just due to chemical imbalances. Certainly, neurotransmitters are important, but that doesn't mean that you can have a simplistic understanding of the nature of mental disorder due to imbalance. So it seems that a lot of psychiatry has got, it aims big, but then it doesn't live up to its expectations. There's been all sorts of ideas back to the 19th century about the localization of the brain functions in the brain, and very rarely do we actually find knowledge which kind of pans out very clearly. In terms of psychiatric practice, psychiatrists may use things like blood tests or brain scans in order to rule out other sorts of causes of mental illness. But if you look at the diagnostic manual, no neuroscience is used to identify mental disorders. There's a big mismatch between how psychiatry presents itself as being very much rooted in the brain and how it's actually practiced. It's generally practiced by looking at people's behavior and their emotions. It's also worth noting that there's a good deal of debate about even to what extent psychiatric medications are helpful in the long term. Most tests tend to be in the short term, and so it seems like probably some are helpful, but there's debate about that. So my tentative conclusion, in some ways the most important part of the talk, is that what we should aim for is kind of pragmatism and not reductionism. We should aim for an approach where we should do whatever is useful in our conception of helping people, and right now, we don't have anything like a foundational science of human behavior rooted in the brain. We have some ideas and there are some theories which are interesting, but there's no fundamental kind of well-confirmed theory. We'd like that, but it doesn't seem as necessary for our psychiatric practice. So the heart of a pragmatic approach is rather than believing in some kind of foundational neuroscience, we should just go with whatever levels of description are useful. All right. So I know I'm running up on my time, so I will go very quickly through the second portion of my talk, which is on neuroscience, on Buddhist approaches to mind. And I think this will be a lot more familiar to you, so I'm not going to go over it in a huge amount of detail, but there are ideas of anatta and non-self, dependent origination, momentary consciousness, and the mind as constructor of reality. These are important ideas in Buddhist thought. And we can see lots of ties between Buddhist approaches and Western psychology. It's complicated, but we should be. There are some clear connections. If you look at some of the practices actually done in modern psychiatry, then there are things like mindfulness-based stress reduction and mindfulness-based cognitive therapy and compassion-focused therapy and mindful self-compassion. And you can see links between those sorts of things and Buddhist approaches. Certainly, we can see ways in which ideas of rejecting the ideas of fixed identity or some kind of fixed self and moving towards a non-self view can actually be useful in a lot of clinical practice. I won't worry about contemplative neuroscience. I will briefly mention acupuncture. Acupuncture is something which is not very mainstream in contemporary psychiatry, but it does get used a lot, and there are clear uses of acupuncture for psychiatric conditions such as anxiety, depression, insomnia, pain, PTSD. All right, so that leads me to the end of my talk. And part 3. And so basically this is just kind of summarizing and what I wanted to say in the first part and linking it to Buddhism. The main thing I want to say is that there's autonomy between the psychological level of description and then the neuroscientific ones. So I'm rejecting a simple reductionism. And I'd say that also applies to philosophical approaches and phenomenological approaches. You don't have to link it to neuroscience in any strict way. You can see links, so sometimes that's going to be useful. So that's going to be true for a lot of Western psychology, but it's also going to be true for Buddhist psychology. You don't need to have a strong link between the psychology and the neuroscience. It might be interesting, it might be a useful form of inspiration for research, but it's not a necessary connection in order for scientific validity or for us to believe in it. So, as I was saying before, I think pragmatism should be our main concern. We shouldn't be specifically worried about justifying one correct theory. Rather, with all these different theories around, we should look at what is useful to us in living. And I think this leads to a certain kind of instrumentalism. It leads to a certain skepticism about whether you can actually come up with one true theory, and it leads us to a view that there could be many compatible different views, and we can adopt different views whenever they're useful to us. So that's what I've got to say. I hope that was somewhat useful to you, and that's the end of my talk. Thank you.